Hey everyone, this is part 2 to Osteoporosis, everything you need to know for the boards and clinic. There just wasn't enough time in the first part to make it through all the fun material, so this part is actually much less board relevant and much more for any of those of whom in part 1 were interested to kind of dig a little bit deeper. So just to kind of go through the initial roadmap, we were going to get you guys to be experts in screening, diagnosis, and therapeutic approach to osteoporosis. And my hope was that once we got through all the questions, we could get to this more interactive session that I titled Below the Surface, where you guys could tell me what you were interested in learning more about, and you could jump to a section to kind of see that data in more depth. But since we ran out of time, I figured I would just make this recording where we go through each of those sections in a little bit more detail, and also I will have the YouTube video indexed so that you can jump to whatever section interests you. But yeah, just to, I guess, jump to that below the surface portion, we can look at the data that tells us about fracture reduction, the difference that the order of medications makes, the mechanism of action of these medications, how glucocorticoids could affect your treatment regimen and screening, the relative cost of these medications, what happens if you stop them, the data behind these atypical femur fractures and osteonecrosis, and then also where the experts get their guidance on how often to repeat DEXAs. So I'm actually going to start with this DEXA data. So as I alluded to in part 1, even though the boards doesn't really recommend getting repeat DEXAs because they cite literature that says that getting repeat DEXAs doesn't do anything to reduce your fracture risk, expert opinion recommends getting repeat DEXAs about every 2 years if you have osteoporosis and you're on medications, because this can give you some information about if the medications are working, or if you should consider changing your treatment regimen, or if maybe it's time for a holiday. Insurances tend not to allow you to, or won't cover getting DEXA screens any more frequent than every 2 years. But then there was some data from this 2012 New England Journal article that kind of suggested that if you were found to have a totally normal bone density, you probably don't really need another DEXA scan for another 10 to 15 years. And then if you fall somewhere in between, you might consider getting a repeat DEXA somewhere in between this 2-year and 15-year range. But just to kind of show you the data that came out of this 2012 study that kind of informs this expert recommendation, what they did is they divided patients with osteopenia into 3 cohorts: those that they deemed closer to normal, those that were closer to osteoporosis, and those that were somewhere in between. Here on the y-axis, we'll look at the incidence of osteoporosis. And the question that they had was, how long does it take one of these cohorts, whether you're closer to normal, closer to osteoporosis, or in between, how long does it take 10% of one of these cohorts to progress to having a T-score that is diagnostic for osteoporosis? So here on the x-axis, we'll look at years since the baseline study, going towards the left. And what they found was that for this lower risk group that had T-scores that started off closer to normal, it took almost 18 years, 17 and a half years, for 10% of that cohort to end up with a T-score consistent with osteoporosis. For that middle group, it took about 4.5 to 5 years. And for this group that was already pretty close to osteoporosis, they progressed much quicker, taking only 1 year. So this is kind of where this expert, or these expert guidelines, or I shouldn't say guidelines, but recommendations come from. And that's pretty much it for that. Next, we'll move on to some of the data behind each of these drug classes. So I'll start with the bisphosphonates, the alendronate. Kind of the landmark trial for this one was FIT1 in 1996, published in The Lancet. And I guess what I'll just draw your attention to here, because I'll draw your attention to it for each of the landmark studies for each of the major drug classes, is kind of, how many people were included roughly, what the T-score, inclusion criteria was, and what the average age was. So for here in the this landmark alendronate trial, FIT1, there are about 2,000 women. They were looking at women with T-scores of less than 2 or a previous spine fracture, and the average age was 71. And here you can see that the difference in, or the fracture reduction in those who were on alendronate for 3 years compared to those that were taking placebo was that the incidence of spine fracture went from about 15% to 8% with a delta of an absolute change of 7%, but a relative risk that looks much more impressive. And if we look at the hip, it went from 2.2% to 1.1. Again, an impressive relative risk reduction, although the absolute risk, about 1.1%. Next up, I'll include the IV formulation of the bisphosphonate zoledronic acid landmark trial in 2007 called Horizon, which was published in the New England Journal. Here, there are slightly more women included, similar age, about 73 this time, with a T-score a little bit worse than that included in the alendronate trial, with T-scores of negative 2.5 or a previous femur fracture. And here we see that the reduction in spine fracture went from about 10.9 to 3.3. And at the hip, it went from 2.5 to 1.4. Next up, I'll include the rank ligand inhibitor Denosumab, with the landmark trial being Freedom in 2009, also published in the New England Journal. Once again, average age was about 70, 72 in this one. Similar to the zoledronic acid trial, it had about, it had roughly 7,800 women, also with T-scores of minus 2.5. They capped it at negative 4. And here we see the intervention arm dropped their spine fracture incidence from 7.2% in the placebo group to 2.3 at the spine, and at the hip from 1.2 to 0.7. Last up in these kind of like landmark trials that I'll include in this presentation is the one looking at teriparatide, which was the FPT trial, also published in the New England Journal in 2007. Similar to these other ones, mean age was 70, with about 1,600 women included, with T-scores of negative 1 or less than negative 1.0 or a previous spine fracture. Here we saw a reduction in the spine fractures from 15% to 5%. And they actually didn't include data, or at least maybe in the supplemental that I didn't look at, but for the hip fractures. One other way to look at some of this would be, rather than looking at reduction in spine fractures, to look at improvement in bone mineral density, which we'll look at on the next slide here. One thing I just want to remind you guys, though, even though I'm about to overlay a representation of the data from each of these landmark trials, these were not head-to-head comparisons. When there were head-to-head comparisons, I'll do my best to point that out, but what I'm just going to show here is if you took the figures from each of these landmark trials and overlaid all of them into one. Again, it's not completely fair to do that because they were different populations. I just thought that it's interesting to kind of look at it in this way. So interpret it as you will. But yeah, that's what I'm about to show. So here for the FIT1 trial looking at alendronate, you can see the increase in bone mineral density in the intervention arm compared to placebo here in the dashed line, and the placebo I'll always represent by the dashed line with the intervention in a solid color. We'll then look at it for zoledronic acid, its increase in bone mineral density as a percent at the spine. Denosumab seems to do a little bit better. And then finally here I've got teriparatide, which seems to have an even more impressive improvement in the bone mineral density at the spine. Again, unlike these three, teriparatide is the one anabolic agent represented in this overlay. Then at the hip, we'll see that the alendronate also increased bone mineral density at the hip compared to placebo, as well as zoledronic acid. Slightly improved increase with the denosumab, and here for teriparatide, not quite as impressive as an improvement at the hip as at the spine. Just because this is a little smushed. If you look at the y-axis here, I kept the y-axis the same 10%. In the actual figures in the primary literature, they changed the y-axis just to make it a little bit more obvious. So I'll do that here, just so that you can see the split a little bit better. Once again, these were not head-to-head trials, but for each of these individual landmark trials, you can see that at the hip, denosumab came out on top, then zoledronic acid, and then alendronate. The next thing I was going to draw your attention to is there was an article published in Nature Review Endocrinology in 2015 where they did something similar to what I just showed in the previous slides, where they took the data from the extension studies for each of these landmark trials and kind of put them together in a figure, which I've kind of adapted here. So the initial landmark trials looked at all of these changes in bone mineral densities over a 3-year period, but then they all did extension studies. So here we see, you can kind of see the curve for the improvement in bone mineral density for denosumab versus zoledronic acid and alendronate. And you can see that things really kind of level off in terms of the bone mineral density improvement for both the bisphosphonates here. So when we talk about that, you really might want to consider a holiday and repeating a DEXA after 3 years. Once again, you can kind of see here that you tend to lose so much bang for your buck after 3 years for the bisphosphonates. And while things seem to keep increasing for denosumab at the hip, it's actually even more impressive at the spine. So here now we'll look at the increase at the spine, and just to compare the slope of the curve, you can see that at the 8-year mark, it kind of just seems to keep increasing. And actually in their extension study, they took the placebo arm and then gave them denosumab, and you can see, you really see this impressive effect at the spine. Which again, at this point, it's been studied for roughly 10 years, and you really seem to just have continued improvement. And that's why, at the moment, it's been approved for 10 years, because that's how long it's been studied. I'll bring you back here. This is not representing a head-to-head trial. This is just representing, the data from the FPT in 2007 and the FIT1 in 1996. But I now will show you an actual head-to-head comparison based on data from the FPT. And again, even though this wasn't head-to-head, I thought it was interesting to see the representation if you overlay it. Because even though these were different populations, if you look at the group that got alendronate in the FPT trial in 2007, I just think it's interesting to note that even though they're different populations, it does map somewhat similarly, somewhat reproducible data at the spine, and certainly it's very close at the hip. Then I think the next thing I wanted to show here was to see how these all stack up to the newest medication on the market, romosozumab, the sclerostin inhibitor, that, although this landmark trial was published in 2014, it wasn't approved by the FDA in the US until 2019. But just to see it, overlaid with these other landmark trials, you can see it really blows everyone else out of the water in terms of the increase in bone mineral density at the spine. And it also wins out at the hip. Again, romosozumab, in terms of its mechanism of action, which we can discuss a little bit more later, it has both anabolic and anti-resorptive properties. Now, it turns out that the romosozumab trial actually did do a head-to-head comparison between alendronate and teriparatide. So in this lighter shade here, I've just included the old data from the landmark trials, just again to see that even though these were different populations, the data does appear to be somewhat reproducible if you look at what they got in terms of alendronate and teriparatide. One note here is that it was studied only for 1 year, as opposed to these initial landmark trials, which were continued out for about 3 years for the bisphosphonate and 1.5 years for teriparatide. And similarly, it and this is the head-to-head data from the 2014 trial. You can see that it had a very impressive increase in bone mineral density at the hip as well. All right, so for this next section, we'll look at does the order of medications matter? So in part 1, I emphasized that for the boards and in MixApp, they prefer you to start with less expensive medications, such as bisphosphonates, before working your way up to some of the more effective medications like denosumab, teriparatide, or romosozumab. But what we'll still see here is that if you do studies to look at the effect of starting one of the anabolic agents before the bisphosphonate or before the anti-resorptive, you appear to get more bang for your buck. So we'll take a look at that now. So again, this is just the old data. This is looking at data from the landmark trials of teriparatide and denosumab. But we'll just extend this graph out a little bit for time. And we will now overlay it with this 2015 study in The Lancet looking at giving teriparatide and then denosumab, or vice versa. So when they gave teriparatide first, followed by denosumab, you see quite an impressive increase in the bone mineral density. Again, looking at just the effect of, from these landmark trials compared to when you do it in this order, you get quite an impressive increase. That's in comparison to when they gave the denosumab first. And again, I just left this old data here just for your own interest to see, that does still seem to be reproducible to that old data. But then when they followed that with teriparatide, it did still continue to increase, but you can see it wasn't as good as when you gave the teriparatide first. So when anabolic came before anti-resorptive, you got more bang for your buck. That was true for both the spine, and again, I'll just draw your attention to this little icon here, the spine, as well as the hip. So when anabolic came before anti-resorptive, more bang for your buck. Here, we'll look at, once again, the data from the extension study of denosumab at the spine, but now we'll compare it with if you give the sclerostin inhibitor, which is romosozumab, and then follow it with denosumab. So here, once again, we see this really impressive increase in the bone mineral density, but if you chase it with denosumab, you get even more bang for your buck. As it turns out, pretty much everyone recommends always doing one of these anabolics followed by an anti-resorptive, but never an anabolic to another anabolic. So you wouldn't go from romosozumab to teriparatide or a PTH analog. You'd always go from an anabolic to an anti-resorptive. All right. So here we'll now look at what happens if you stop the denosumab and don't follow it with anything. So that's what was looked at in 2011. And you can see that here, this is when the denosumab was stopped, and you get a very steep decline. You basically lose everything that you gained in just a few months, both at the spine and at the hip. And although I didn't include it here, you get this rebound increase in fracture risk, which actually exceeds fracture risk prior to starting your therapy. So this is why I tried to emphasize in part 1 that if you're going to stop denosumab, if you're going to stop rank ligand inhibitor, you really got to chase it with another anti-resorptive, the most common one being zoledronic acid, the IV formulation of the bisphosphonate. So yeah, if you're going to stop, you really got to chase it with a bisphosphonate to maintain the bone mineral density that you got and not have this rebound increase in fracture risk. One thing that I also just thought I would bring to your attention is that this 2011 study was authored by Dr. Henry Bone. So Dr. Bone has published extensively on the topics related to disorders of the bone. Same thing you see with teriparatide. So this is another one. If you stop teriparatide, you also can see a pretty steep decline. So this is another one where they recommend chasing it with an anti-resorptive, and that's really true for all of these agents. So romosozumab, they would recommend chasing as well. All right, next up, earlier when we discussed the side effects of the medications, we noted that atypical femur fractures and osteonecrosis of the jaw are side effects of the bisphosphonates and rank ligand inhibitors, although they're very rare side effects. So in part 1, I alluded to the fact that you're more likely to get struck by lightning in New Mexico, and I'll show you where I came up with that statement in just a bit. But just to, I guess, kind of define what we mean by atypical femur fractures. So they came up with these criteria, of which you need 4 of 5 in order to even call it an atypical femur fracture. So 90% of hip fractures will occur within the femoral neck, or the intertrochanteric region, which I've kind of tried to represent in this schematic here, with only 10% being subtrochanteric fractures. Which is where you tend to see your atypical femur fractures. That said, even of this less likely group, less than 0.5 are thought to be atypical femur fractures. But the features that they're looking for, again, 4 of the 5 being required, are minimal to no trauma, a fracture line that originates at the lateral cortex, a complete fracture that extends through both cortices, possibly with a medial spike, a non-comminuted or minimally comminuted fracture, and then periosteal or endosteal thickening of the lateral cortex, which they call beaking. So just to show you what some of these things refer to, so here's a complete transverse fracture, which is clearly subtrochanteric. Here you see that this thickening of the lateral cortex, which they refer to as beaking here. I guess I'll turn on the laser pointer to kind of point out maybe that beak that they're referring to, and this cortical thickening, which they represent here at the cortices. Now, in 2011, there was a Swedish cohort that they looked at, 1.5 million women, or I guess they were looking at them in 2008. 75,000 of them had bisphosphonate use. 13,000 of those developed femur fractures, of 1,200 of whom had subtrochanteric fractures, but only 59 of those had atypical femur fractures. So that's kind of where this less than 0.5% comes from. That said, the risk of fracture in bisphosphonates users is higher than those who are not taking bisphosphonates. So here in the same cohort, when you looked at individuals who developed any fracture compared to those who weren't taking bisphosphonates, we see that the relative risk was about 1.32, and you see that there was an increased risk of hip fracture in the bisphosphonates users. But again, that's not because they were taking bisphosphonates. That's because these individuals were more prone to hip fractures to begin with. And but when you compare that to those with the atypical femur fractures, the odds ratio or relative risk is much, much higher. So it was 5.5 in the bisphosphonate users, which is not a high number, in and of itself, but compared to the non-bisphosphonate users, it was only 0.09. And just to point out, this is referring to the incidence per 10,000 patient years. That said, while the relative risk was only 1.32 for any fracture, it was 47 for the atypical femur fracture. So there does seem to be a signal that bisphosphonates do increase the risk, albeit the absolute risk is low, but there is a signal there. And when they did a multivariate analysis for the adjusted odds ratio, you see that the longer that you're on the bisphosphonate, the more likely you are to develop this atypical femur fracture. And if you try to calculate the number needed to treat, you can see that in order to prevent a hip fracture, you only need to treat 91 patients. To prevent a vertebral fracture, only 14. But the number needed to harm is 667. So, I mean, this is why we consider that the benefits outweigh the risks. Oh, and by the way, this data, again, this is all from this Swedish cohort, and these are moderate risk patients. So, you know, this number needed to treat versus number needed to harm diverges even more in the higher risk group, where you would need to treat a lot more in order to harm them, as you're higher risk for fracture and have worse osteoporosis. Whereas those who are lower risk and don't have osteoporosis and maybe just have osteopenia, these numbers will converge. So that's why we don't really treat those with osteopenia anymore. All right, in terms of me quoting this, you being more likely to get struck by lightning. So that actually, I think, originated with this Dr. Lewicki, who's the director of osteoporosis in New Mexico. And there was a column where, patients could write into him and ask questions. So someone wrote in and said that they were completely befuddled by these frightening stories that they were hearing about the side effects of the bisphosphonates, and that they were afraid to take the medication because of it. So he responded, and it was here where he noted that these side effects are quite rare, and the risk is about the same as death by lightning. So again, this is for osteonecrosis of the jaw as opposed to the atypical femur fractures, but yeah, both of them are just considered to be incredibly low risk, and truthfully, they occur so infrequently that the studies just aren't really even powered to figure out the true risk at this time. All right, now to just go through mechanisms of action. So as we discussed earlier in part 1, you've got your osteoblasts that lead to bone formation for formation of new bone, and your osteoclasts that tend to eat up or resorb your old bone. And then you've got some precursor cells. So normally, your osteoblasts release this molecule called rank ligand, which binds to the rank receptor and promotes the formation of more osteoclasts. In terms of your SERMs, the SERMs increase this endogenous molecule called osteoprotegerin, which binds to the rank ligand and thus decreases the amount of osteoclast activity. So it increases osteoclast apoptosis and decreases osteoblast apoptosis. So that's osteoprotegerin. Now, denosumab is a synthetic version of that, essentially. So it also inhibits the rank ligand and, essentially, causes less of the osteoclasts and more of the osteoblasts. Bisphosphonates have several mechanisms of action. They enter osteoclasts and inhibit this FPP synthase. They decrease the attachment of the osteoclasts to the bone and thus prevent them from doing their resorption. And they also increase osteoclastic apoptosis. And then this new medication, the sclerostin inhibitor romosozumab by the brand name Evenity. So to kind of distill its mechanism of action, it turns out that sclerostin, the molecule seen here, normally inhibits osteoblast proliferation. So if the sclerostrin gets to the osteoblast precursor, it prevents it from turning into a full osteoblast. And osteocytes, which are kind of in the bone, they naturally reduce sclerostin release when your bones are under stress to promote bone formation. But if you're an astronaut and your bones aren't under stress and they're not feeling any pressure, it turns out that the sclerostin will increase, and thus you will lose osteoblasts and lose bone density. So this new medication, Denosumab, inhibits the sclerostin and thus allows more formation of osteoblasts and increased bone mineral density. One in between here that I didn't include is Wnt, but that kind of just makes this whole mechanism a little bit more complicated to describe, but for completeness sake, I will include it here. All right, next up, we can talk about the relative cost. So as I alluded to earlier, as you go down this list, the medications get more and more expensive, which I tried to represent by these little dollar icons here, with each one representing about $100. So Ledronate's about 100. These numbers I kind of got from goodrx.com. But yeah, the Ledronate's about $100 yearly, as opposed to the IV formulation, which is about $1,000, compared to about $1,600 for Denosumab versus about $10,000 for the PTH analog teriparatide. And the newest one, at least at present, looks like it's about $22,000 a year. And I didn't even include the number of dollar icons here to represent that, because it would take up the whole page. To discuss glucocorticoid and how that would affect your management and screening, this is a little bit complicated, and for the most part, I would refer you to the American College of Rheumatology guidelines. But I guess to kind of break it down a little bit, the best data that we have is really for adults that are over 40. The data gets a little bit blurrier for younger individuals, but essentially they kind of recommend that if you're taking more than 2.5 milligrams of prednisone daily for more than 3 months, that you could consider treating these individuals as you would those with osteoporosis. And then similarly, if you have adults, younger individuals that are taking a higher dose, they say 7.5 milligrams for more than 6 months, you could consider treating them. The data shows us that the fracture risk while you're on glucocorticoids is greatest in the first 12 months. You see these really steep increases. The ACR does recommend getting a DEXA for anyone that's 40 years of older that's really on any glucocorticoid regimen for more than 3 months. And you can stop the therapy once you stop your glucocorticoids, but you should consider treating long-term if you're going to continue your glucocorticoids long-term. Next up, I think I have here some interesting data from astronauts that we obtained. So this is Dr. Scott Smith, and he works for NASA, and he publishes a lot of material on what happens to your bones in space. And if we go back to this picture of him in the lab, you will see these jugs behind him that kind of look like they contain urine, and that's because they do. So I apologize, I meant to include a source here, but this clip is from the YouTube channel Smarter Every Day, but I'll just play a brief clip of it here now for you.
You're putting it in the machine?
Yes, I'm diluting it. 1 to 100.
How does it feel to know that a national treasure is in your hands, that national treasure being astronaut urine?
It's really something special.
What a great way to answer that question.
This instrument is looking at urinary calcium.
So you're saying that that's where the bone mass goes? They pee out their bones?
They pee out their bones.
Whoa! There's a fire going on in here. You didn't tell me that.
No, I didn't tell you.
What's up with the fire?
The machine injects a sample into that flame.
Okay.
And then as it burns, what happens is the machine measures the absorption of light. And based on standards and curves, you're looking at, it absorbs different wavelengths from that heat and tells you where the calcium is.
There's a lot of big words happening right here, but I want us to stop and think about what's actually happening. We're taking astronaut pee and we're burning it. And we're looking at the color of burnt astronaut pee. Is that correct?
That's correct. In crew members of the ARAD, when they...
So, what Destin from Smarter Every Day is telling us there, or is showing us, is that, when you go up into space, when you go up into space, you end up peeing out your bones. And what they've learned about what happens to your bones in space comes from taking this astronaut urine and, as he said, burning it and kind of figuring out the amount of calcium that comes out. What they've figured out is that you can prevent all of that bone loss using this weight training in space. So they developed these fancy exercise equipment that relies on vacuums. But once they, got these into the space station, they were finally able to...
Putting it in the machine?
We'll look at that in the next slide here. So, here he's just showing that, you lose about 1.5% of your bone mass per month. But finally, when they incorporated this fancy exercise equipment, the ARED, they finally were coming back with bone densities that weren't worse than when they started. Just to show you what this looks like.
Their bone mineral density was the same as it was before flight.
And that's never happened before.
And that's never happened before with good diet and hard exercise. This is the...
And then just to catch some of my audience's interest, I figured I would include a bit about the relationship of all of this and UFOs. So here I'll play a quick clip from Tim Peake, a European Space Agency astronaut, describing his encounter with what he thought was a UFO.
Also, in the book you talk about how, for a moment, you thought you saw UFOs.
It was hilarious. And in the daytime in space, the space is black, the blackest black you could ever imagine. And if you see a light, it's just another spacecraft coming towards you. And we do when cargo vehicles arrive or crew handovers come over, you see these lights. On this one day, I was looking out and I saw 3 lights flying in formation. And I thought we're not due a visiting spacecraft today. And I called over Jeff Williams, my NASA crewmate, and said, "Hey, what do you make of that?" And he was equally perplexed. And then a 4th light joined them, all in formation. And then suddenly we realized that we thought it was lights that were far away. It was actually small droplets of light that were very close. And what was happening, a liquid was leaking out the Russian Progress vehicle, and it was crystallizing instantly and then reflecting the light. And it turned out to be Russian urine that was leaking out of the tank. So
like animals, view. Animals as Russians. No one's ever been more relieved to see Russian urine.
All right. So yeah, that's pretty much all I've got. I think the only last little Easter egg I had in here was this, which is a picture that recently got honorable mention in a Nokia contest, looking at the structure of dinosaur bone, which I just think is interesting because you can see this kind of porous structure isn't so dissimilar to what we see in our own bones and what occurs during the osteoporotic process. But yeah, with that, that's really all I've got for you for this below the surface material. So for anyone that was interested, hope you enjoyed.